Welcome back to the Vital Signpost. Ready for another deep dive. Today we're tackling antilipemic medications. You know, those drugs we use day in and day out to help our patients manage those tricky lipid disorders.
And of course, prevent coronary heart disease. A pretty vital topic for nurses, wouldn't you say?
Absolutely. By the end of this deep dive, you'll be able to rattle off the mechanisms of action of every antilipemic drug out there, not to mention their benefits, side effects, and, all those nursing considerations.
We're going to start with the fundamentals, like what exactly are lipids, what are triglycerides, and cholesterol.
And why are they so important when it comes to heart health? Because we always hear all this talk about good cholesterol and bad cholesterol, but what does that even mean?
Well, lipids are, fats,
Mm-hmm.
and they're actually essential for a lot of things our body does.
Right, like building cells
And making hormones.
and storing energy.
But when it comes to heart health, it's all about balance.
Because too much of a good thing, as they say.
Exactly. Too much of certain types of lipids can actually spell trouble for our cardiovascular system.
Okay, so let's break this down a bit. First up, triglycerides. What are they exactly?
Triglycerides, they're basically the main way our body stores energy. They're stored in our fat tissue, adipose tissue. Think of them like our energy reserves.
Okay, so kind of like our backup fuel supply.
Yeah, exactly. Now, cholesterol, that's a bit different. It's used to build cell membranes, and it's a key ingredient for making hormones and bile acids.
Which we need for digestion.
Exactly. So you see, cholesterol isn't inherently bad. It's actually vital.
Right, it's all about the right amount.
Absolutely. Now, this is where things get a little more complicated because both cholesterol and triglycerides, they can't just travel freely through our bloodstream. They're insoluble in water.
So they need a little help getting around.
That's where lipoproteins come into the picture. Think of them as specialized carriers. They're proteins that encapsulate cholesterol and triglycerides and transport them through the bloodstream.
So like tiny little transport vehicles.
Yeah, you could say that. And these vehicles, they come in different forms, each with a specific job to do.
Okay, I'm intrigued. Tell me more about these lipoproteins. What kinds are there?
Well, first we have chylomicrons.
Chylomicrons. Sounds a bit intimidating.
Don't worry, they're actually the good guys. Their main job is to transport dietary fats, the fats you eat, from your intestines to your liver.
So they pick up the fats from our food and deliver them to the liver for processing.
Exactly. Then we have very low-density lipoproteins, or VLDLs for short.
VLDLs, another acronym to remember.
You'll get the hang of it. VLDLs are responsible for carrying triglycerides from the liver to other tissues in the body.
Okay, so they distribute triglycerides.
Precisely. Now, this is where we get to the bad cholesterol, the LDL.
LDL, the one we always hear about in the news. What makes it so bad?
LDL actually does deliver cholesterol to cells, which is important. But when there's too much LDL circulating, it can start to accumulate in the walls of our arteries.
Not good.
Not good at all. This buildup forms plaque, which narrows and hardens the arteries. That process is called atherosclerosis.
Atherosclerosis, that's the
Yeah.
one that can lead to heart attacks and strokes, right?
Right. And then we have HDL, the good cholesterol.
HDL, our hero.
HDL particles actually act like scavengers, picking up excess cholesterol from the bloodstream and transporting it back to the liver. Think of it as a cleanup crew for your arteries, keeping things flowing smoothly.
So HDL helps prevent that dangerous plaque buildup.
Exactly. It's all about keeping that balance between LDL and HDL. Now, before we dive into the medications that can help manage cholesterol levels, I want to touch upon a couple of herbal therapies that some people use.
Okay, like what?
Well, one that comes up often is garlic. It's got that active ingredient, allicin.
Yeah, the one that gives it that pungent aroma.
Right. Some studies suggest that garlic might modestly lower total cholesterol and LDL levels, but more research is needed.
So it's not a sure thing.
Not quite. Then there's flaxseed. It's rich in omega-3 fatty acids.
Omega-3s, those are good for the heart, right?
You bet. They can help lower triglycerides and potentially even improve blood pressure.
But is flaxseed as effective as medication?
Well, here's the thing. While these herbal therapies might have some potential benefits, they shouldn't replace conventional medical treatment.
It's always best to talk to a healthcare provider before trying any new remedies.
Absolutely, especially if you're already taking medications, there could be interactions.
Right, safety first. Okay, so we've talked about the different players in the cholesterol game. Now, let's dive into how our body actually manages cholesterol. This whole process is called cholesterol homeostasis, right?
You got it. Think of it as a carefully choreographed dance, keeping everything in balance.
Okay, walk me through it.
So imagine you've just had a meal.
A delicious, satisfying meal.
Right. Your digestive system gets to work breaking down those fats from your food into triglycerides. Those triglycerides are then packaged into chylomicrons. Remember those transport vehicles?
Yeah, the ones that pick up fats from the intestines.
Exactly. Those chylomicrons enter the lymphatic system and eventually make their way to the liver.
The liver, the grand central station for lipids.
Precisely. The liver receives those dietary fats, but it also makes its own triglycerides and packages them into VLDL particles, those very low-density lipoproteins we talked about. Those VLDLs then enter the bloodstream and deliver triglycerides to different tissues throughout the body.
Okay, so they're like the delivery trucks for triglycerides.
Exactly. Now, as those VLDLs circulate, an enzyme called lipoprotein lipase, or LPL for short, breaks down the triglycerides. And this transforms VLDLs into IDL, intermediate density lipoproteins.
IDL, another type of lipoprotein.
Right. And IDLs, they undergo further processing and eventually become, you guessed it, LDL particles.
So LDLs are like the final product of this whole VLDL transformation.
You got it. And remember, LDL's main role is to deliver cholesterol to cells. But as we discussed, when there's too much LDL, that cholesterol can start building up in the artery walls, leading to those atherosclerotic plaques.
And that's where HDL, the good cholesterol, comes in to save the day, right?
Exactly. HDL particles are produced in the liver and intestines. They act like those scavengers we talked about, picking up that excess cholesterol and taking it back to the liver for removal.
So it's a constant cycle of delivery and removal, like a delicate balancing act.
A great way to put it. Now let's talk about what happens when this balance is disrupted, when cholesterol levels are elevated.
This is when things can get a bit dicey.
You got it. Imagine the inner lining of your arteries like a smooth, healthy surface.
Like a freshly paved highway, ready for traffic.
Perfect analogy. Now, when cholesterol levels are high, particularly those LDL levels, certain white blood cells called monocytes sense that imbalance and they start attaching to the artery walls. They then burrow into the artery wall and transform into macrophages.
Macrophages, those are like the body's Pac-Man.
Oh, yeah.
Go around gobbling up invaders.
Right, and in this case, they start gobbling up cholesterol from those circulating LDL particles.
So they're trying to do their job, but it backfires?
In a way, yes. Because these macrophages, they become engorged with cholesterol and transform into what we call foam cells.
Foam cells. That sounds kind of ominous.
Well, they are, because these foam cells, packed with cholesterol, accumulate within the artery wall and form the foundation of atherosclerotic plaque.
So it's like a buildup of fatty debris in the artery, gradually narrowing the passage.
Exactly. This buildup can eventually lead to a complete blockage of the artery, depriving the heart muscle of oxygen and nutrients. And that's how you get a heart attack.
So this is why managing cholesterol levels is so crucial for heart health.
Absolutely. And it's not just about preventing heart attacks. Atherosclerosis can affect arteries throughout the body, leading to a whole range of problems.
Like what?
Stroke,
Oh.
peripheral artery disease,
And even?
even erectile dysfunction.
Wow, the implications are far-reaching.
They are. Now let's talk about how this all relates to coronary heart disease, or CHD. As we've seen, high cholesterol, especially high LDL, is a major risk factor.
And CHD is a leading cause of death worldwide.
That's right. Those elevated cholesterol levels contribute to the formation of plaque in the coronary arteries. You know, the blood vessels that supply oxygen-rich blood to the heart muscle.
And when those arteries become narrowed or blocked, that's when we can see chest pain, shortness of breath, and in severe cases, a heart attack.
You got it. And here's the thing, CHD often develops silently over many years. Many people don't even know they have high cholesterol until they experience a cardiac event.
That's scary.
It is. That's why routine cholesterol screenings are so important, so we can catch it early.
Early detection and management is key.
Absolutely. So, how do healthcare providers determine when someone needs medication to manage their cholesterol? Is it just based on having high cholesterol?
It seems like there's more to it than that.
You're right. It's not just about the numbers. The decision to prescribe antilipemic drugs, especially statins, which are often the first-line therapy, is based on a careful evaluation of the patient's risk factors.
Like their age,
Exactly. Family history of heart disease,
whether they smoke,
blood pressure,
diabetes.
and other cardiovascular risks. It's a personalized approach.
So it's like putting all the pieces of the puzzle together to get a full picture of their cardiovascular risk.
That's a great way to put it. And based on that assessment, healthcare providers use evidence-based guidelines to figure out the best course of treatment.
Okay, that makes sense. Now, before we dive into the specifics of the different antilipemic drugs, can we talk about phenotyping?
Phenotyping.
Yeah, I remember reading about it. It's basically a way to categorize different lipid profiles, right?
Oh, right. You mean like creating a fingerprint of their lipid profile? It helps healthcare providers tailor treatment strategies. Well, yeah, phenotyping involves analyzing a patient's blood lipid levels to figure out their specific lipid disorder.
So it looks at total cholesterol,
Uh-huh. LDL cholesterol.
HDL cholesterol,
Yeah.
and triglycerides. And then it classifies lipid disorders into different phenotypes.
So it's like creating different categories based on those lipid levels. Yeah, you could say that. This classification helps determine the most effective approach, whether it's lifestyle changes, medications, or a combination of both.
Okay, so it's a way to personalize the treatment plan based on their specific lipid profile.
You got it.
Now, I think we're ready to tackle those different classes of antilipemic drugs. What do you say?
Let's do it.
Okay, let's start with the heavy hitters, the HMG-CoA reductase inhibitors, or as they're more commonly known, statins.
Ah, statins. The cornerstone of cholesterol management. They're definitely the go-to medication for high cholesterol.
And for good reason. They're pretty powerful, right?
They are. Statins work by inhibiting a key enzyme involved in cholesterol production in the liver. It's called HMG-CoA reductase.
HMG-CoA reductase.
Catchy name.
It is, isn't it?
Yeah.
So by blocking this enzyme, statins essentially reduce the amount of cholesterol the liver makes.
So they put a stop to the production line.
Exactly. And that leads to a significant reduction in circulating cholesterol levels, especially LDL cholesterol, the bad cholesterol. And that translates into a lower risk of heart attacks, strokes, and other cardiovascular events.
Right. And what's really interesting about statins is that they not only lower LDL, but they also can increase HDL, the good cholesterol.
So they work on both fronts.
They do. But like all medications, they do come with potential side effects.
What are some of the things we need to watch out for?
Well, the most common ones are typically mild. Headache, muscle aches, fatigue, and sometimes GI upset like nausea or diarrhea.
So not too bad. But I imagine there are some more serious side effects that we need to be aware of.
Yeah, there are a few. Liver damage is one concern, although it's pretty rare.
And what about the muscle aches? Are those ever a cause for concern?
They can be. In some cases, statins can cause muscle damage, which is called myopathy. And in severe cases, that can lead to rhabdomyolysis.
Rhabdomyolysis?
That's a breakdown of muscle tissue that can damage the kidneys.
That's serious.
It is. So we need to monitor for any signs of muscle damage, like unexplained muscle pain, tenderness, or weakness.
And what about the liver? How do we monitor for liver damage?
We check liver enzymes through blood tests regularly. That helps us catch any signs of trouble early on.
So regular monitoring is key.
It is. And it's important to educate our patients about what to look for, the signs and symptoms of muscle damage, and tell them to report anything unusual right away.
Being proactive is so important. Now, I imagine there are certain medications that can interact with statins.
Yeah, definitely. Some antifungal medications, antibiotics like erythromycin, even grapefruit juice.
Grapefruit juice, really?
It's true. Grapefruit contains compounds that can interfere with how statins are broken down in the body, leading to higher blood levels of the drug.
And that increases the risk of side effects.
Exactly.
Okay, so we've got to educate patients about potential interactions too.
Absolutely. They need to know about these interactions and talk to their healthcare provider about all the medications and supplements they're taking, and even things like grapefruit consumption.
Right, because it all adds up.
It does.
Now, let's move on to another class of antilipemic drugs, the bile acid sequestrants. How do these medications work? Are they similar to statins?
Not quite. Bile acid sequestrants, they don't interfere with cholesterol production like statins do. Instead, they work in the intestines.
In the intestines.
Yeah, they bind to bile acids.
Bile acids. Remind me, what are those again?
Bile acids are made from cholesterol in the liver. They help us digest fats. But when bile acid sequestrants bind to them in the gut, they prevent them from being reabsorbed back into the bloodstream.
So they interrupt the recycling process.
You could say that. And this forces the liver to use up more cholesterol to make new bile acids.
So it's like depleting the cholesterol stores.
Exactly. Now, while bile acid sequestrants aren't as powerful as statins in lowering LDL cholesterol, they can still be a valuable tool, especially when combined with statins.
Okay, so they can work together. What about side effects? Are they similar to statins?
Not really. Bile acid sequestrants, they're not absorbed into the bloodstream, so they don't cause those systemic side effects we talked about with statins.
That's good. So what do we need to watch out for?
The main side effects are GI related: constipation, bloating, gas, nausea, that sort of thing.
So it's more about managing those local gut-related issues.
Right.
Now, I know we talked about drug interactions with statins. Are there similar concerns with bile acid sequestrants?
Yeah, we do have to be careful about interactions because they can interfere with the absorption of other medications.
The timing is everything.
It is. We usually recommend taking bile acid sequestrants at least 1 hour before or 4 to 6 hours after any other medications.
So that's an important teaching point for our patients. Now, let's move on to another unique antilipemic agent, niacin.
Niacin. It's a B vitamin, but at higher doses, it can actually lower cholesterol.
So it's like a vitamin that moonlights as a cholesterol-lowering drug.
Yeah, kind of. It's essential for a lot of metabolic processes in the body, but at those higher doses, it has this remarkable effect on lipid levels.
How does it work?
Well, it's not completely understood, but it seems to work on multiple fronts. It inhibits the release of free fatty acids from fat tissue, reduces triglyceride synthesis in the liver, and increases the activity of lipoprotein lipase, that enzyme that breaks down triglycerides.
Wow, so it's like a multi-pronged attack on lipids.
You could say that. And what's really impressive is that it has a beneficial impact on all the lipoproteins. It lowers LDL, total cholesterol, and triglycerides while also raising HDL.
That's pretty remarkable. It sounds like a real winner. But I bet it has side effects.
It does. The most common one is flushing. You know, that feeling of warmth, redness, and tingling in the face and upper body.
I've heard about that. Not very pleasant.
No, it can be quite uncomfortable. But there are ways to minimize it. Taking aspirin before niacin, for example, or starting with a low dose and gradually increasing it.
So there are strategies to manage it. Are there any other side effects we need to be aware of?
Gastrointestinal upset is another common one, and itching. And in rare cases, liver problems.
So, like with any medication, close monitoring and open communication with our patients is key.
Absolutely.
Okay, let's move on to the last major class of antilipemic drugs. The fibric acid derivatives, or fibrates for short.
Fibrates, they're the go-to for high triglycerides.
How do they work?
They primarily target triglycerides by activating lipoprotein lipase, that same enzyme that niacin boosts.
So it's like a tag team effort to tackle those high triglycerides.
Exactly. They also have a modest effect on lowering LDL and raising HDL. But of course, they have potential side effects too.
What are some of the common ones?
GI issues are the most common: nausea, diarrhea, stomach pain. And fibrates can increase the risk of gallstones. And in rare cases, they can cause muscle problems or liver damage.
So we need to monitor liver function with fibrates, just like we do with statins.
You got it. And we also need to be aware of potential interactions with other medications, especially statins.
Oh, why is that?
Combining fibrates with statins can increase the risk of muscle problems, especially that serious one we talked about, rhabdomyolysis.
So it's a combination that requires careful consideration.
It does.
Now, I know we've talked about the four main classes of antilipemic drugs. Are there any other options out there?
There are a few.
So we've got a whole arsenal of weapons to combat high cholesterol.
That's one way to put it. One example is ezetimibe. It works by selectively blocking the absorption of cholesterol in the small intestine.
So it intercepts cholesterol before it even enters the bloodstream.
Exactly. It can be very effective in lowering LDL cholesterol. We often use it in combination with statins.
For a double whammy.
Right, and it has a good safety profile.
What about PCSK9 inhibitors? I've heard about those.
PCSK9 inhibitors are really interesting. They're given as injections, and they work by blocking a protein called PCSK9.
PCSK9. And what does that protein do?
It plays a role in regulating LDL receptor activity. Remember those receptors on liver cells that remove LDL cholesterol from the blood?
Yeah, they're like the gatekeepers, letting
Yes.
cholesterol into the liver cells.
Exactly. So by blocking PCSK9, these inhibitors actually increase the number of LDL receptors that are available, which means more LDL cholesterol can be removed from circulation.
So they boost the liver's ability to clear out the bad cholesterol.
That's a great way to put it. They're very effective in lowering LDL cholesterol, but they're usually reserved for patients who haven't had success with other medications or who can't tolerate statins.
So they're more of a specialized tool. What about bempedoic acid? That's a newer one, right?
It is. Bempedoic acid, it works by inhibiting an enzyme involved in cholesterol synthesis, kind of similar to statins.
So it's another way to target cholesterol production right at the source.
Exactly. And it's generally well tolerated.
Sounds promising. It seems like we have a lot of options for managing lipid disorders these days.
We do.
But with so many choices, How do healthcare providers decide which approach is best for a particular patient?
Well, it depends on a few things. The patient's specific lipid profile, their individual risk factors for cardiovascular disease, potential interactions with other medications they're taking, and of course, their preferences and goals.
So it's a shared decision-making process.
It should be.
Yeah.
And lifestyle modifications are a crucial part of the conversation, too.
Right, those healthy habits we always talk about.
Exactly. Eating a heart-healthy diet, getting regular exercise, maintaining a healthy weight, avoiding smoking.
All the good stuff.
Right. Those lifestyle changes can make a huge difference, and sometimes they can even be enough to bring cholesterol levels down without medication.
So it's about empowering our patients to take control of their health.
Absolutely.
Okay, so we've explored the world of lipids and antilipemic medications. Now I think it's time to shift gears and focus on the nursing considerations.
Nursing considerations, that's where the rubber meets the road. How can we as nurses make sure our patients are receiving safe and effective antilipemic therapy?
Right. It's more than just administering medications. It's about integrating all of this knowledge into every aspect of patient care.
You got it. We need to be experts at assessing our patients, identifying potential contraindications, monitoring for both therapeutic and adverse effects, and providing comprehensive patient education.
It's a lot to juggle.
It is, but it's all part of providing the best possible care for our patients. So let's talk about those nursing considerations. It all starts with a thorough assessment.
Okay, back to the basics. What are the essential elements of a good nursing assessment when it comes to these antilipemic medications?
Well, first, we need a complete health history. We need to know about any other medical conditions, especially ones that could be a problem with antilipemic medications.
So we're looking for any potential contraindication.
All right, and we need a detailed medication history.
Everything they're taking, prescription, and over-the-counter.
And any supplements they might be using too?
And allergies, of course.
Of course. And we can't forget about those lifestyle factors that can really impact lipid levels.
Things like what they eat,
How much they exercise,
alcohol use,
and whether they smoke.
those habits can really make a difference.
Absolutely. So we've got all that subjective data from the health history. Now we need to do a focused physical exam.
Okay, what are we looking for specifically?
We start with the basics, of course. Blood pressure, heart rate.
Vital signs.
Right. We also need to assess for any signs of cardiovascular disease,
Things like abnormal heart sounds,
edema,
diminished pulses.
and we should check the skin for any signs of lipid abnormalities.
Like what?
Well, sometimes you see fatty deposits or xanthomas.
Okay, so we've gathered all this information. Now what?
Now we need some lab tests.
To confirm our suspicion.
To get a clearer picture, a lipid panel is essential.
So we can measure total cholesterol,
LDL
HDL.
and triglycerides.
We need those numbers to track the effectiveness of treatment.
Exactly. And with some of these medications, especially the statins, we also need to monitor liver function tests.
To make sure their liver is handling the medication okay.
Right. We want to catch any signs of liver damage early.
Absolutely. Okay, so you've done our thorough assessment. We've started the patient on an antilipemic medication. Now what? What are the key things we need to monitor?
Well, we've got to make sure the medication is actually working.
So we keep an eye on those cholesterol numbers.
Right. And we're watching out for any signs of side effects.
We talked about those earlier, like muscle pain with statins,
GI issues with bile acid sequestrants.
flushing with niacin.
Exactly. And we educate our patients about these potential side effects so they know what to look for and when to call us.
Patient education is so important.
It really is. We want our patients to understand their condition, why they're taking this medication, and how important it is to stick to their treatment plan.
It's about empowering them to be active participants in their care.
Exactly. We explain the benefits of lowering their cholesterol.
How it reduces their risk of those serious cardiovascular events.
Yeah, and how their medication plays a role in all of that.
And sometimes we have to do some myth busting. Especially with statins, there's a lot of misinformation out there.
It's true. We have to provide evidence-based information and help our patients separate fact from fiction.
So they can make informed decisions about their health.
Right. And it's not just about medication.
We have to emphasize those lifestyle modifications too.
Absolutely. Healthy diet, regular exercise, all of that.
Those lifestyle changes can really make a difference.
They can. Sometimes they're even enough to manage cholesterol without medication.
It's all about giving our patients the tools they need to take control of their health.
Exactly. Now, I think it would be helpful to walk through a case study to see how all of this plays out in real life.
A case study. I like it. Let's hear it.
Okay, so let's say we have a patient named Mr. Jones. He's 65 years old, recently retired, Worked construction his whole life.
Mr. Jones enjoying his well-deserved retirement.
Right. Comes in for a routine checkup, and his doctor notices his cholesterol is a bit high.
A bit high. How high are we talking?
Total cholesterol 240, LDL 160.
Yeah, that's not good.
And considering his age and the fact that he's a former smoker, his doctor is concerned about his risk for heart disease.
So what does the doctor recommend?
Lifestyle changes, of course.
Diet and exercise.
Right. And he prescribes atorvastatin, a statin, 20 milligrams a day.
Okay, so Mr. Jones is now on a statin to help lower his cholesterol. Where do we, as nurses, fit into the picture?
Well, we're often the first point of contact for patients who have questions about their medications.
We're the ones they call when they're having side effects or just need some reassurance?
Exactly. So let's say Mr. Jones comes back to the clinic a couple of months later for a follow-up. He mentions he's been having some muscle aches, mostly in his legs.
Muscle aches. That's a potential side effect of statins, isn't it?
It is, and it's something we have to take seriously.
So what do?
We assess, of course, ask him about the pain. Where is it? How bad is it? When did it start? What makes it better or worse?
Gather all the details.
Right, and we want to consider other things that might be causing his muscle aches, too. Like, has he changed his activity level recently? Is he taking any other medications that could be contributing?
Rule out other possibilities.
Exactly. Now, mild muscle aches with statins are pretty common, and they often go away on their own. But we can't just dismiss it, especially if it's persistent or severe.
Right, we have to be thorough.
Absolutely. So in this case, let's say Mr. Jones's muscle aches are persistent and they're actually interfering with his daily activities.
That's not good.
No. So what do?
We check his creatine kinase levels.
Creatine kinase, or CK.
Right. That's a blood test that can tell us if there's muscle damage.
You got it. If his CK levels are high, it could mean he has statin-induced myopathy.
And we might need to adjust his medication.
Maybe lower the dose, maybe switch him to a different statin, maybe even try a different type of cholesterol-lowering medication altogether.
It all depends on the situation.
It does, and throughout all of this, communication is key.
We keep Mr. Jones informed every step of the way. We explain what we're doing and why.
And we address any concerns he has.
It's all about working together. Now, what if Mr. Jones says, I don't want to take this statin anymore. I'm feeling fine, and I don't want to risk these muscle problems. What do we say?
Well, first, we acknowledge his concerns. It's understandable to be worried about potential side effects. Then we gently remind him why managing his cholesterol is so important.
How it can reduce his risk of heart attack and stroke.
Exactly. And we reassure him that we're monitoring him closely, we're watching for any signs of trouble, and we're here to help him find a solution that works for him.
So it's a collaborative approach.
It is. Now, I think it's time to review some key terms related to antilipemic therapy and nursing care.
Okay, key terms. These are the words we need to know to really understand this stuff.
Exactly. Let's start with antilipemic drugs. What are they?
Well, we've been talking about them this whole time. They're all the medications that lower lipid levels in the blood.
The statins, the fibrates, the bile acid sequestrants, they all fall under that umbrella.
Okay, that makes sense. What about apolipoproteins?
Lipoproteins. Remember those lipoproteins, those little transport vehicles for lipids? Well, each lipoprotein has a protein component, and that's the apolipoprotein.
So it's like the name tag on the vehicle.
Yeah, I like that. It helps identify the lipoprotein and tells us what its job is.
Okay, that makes sense. Now, cholesterol, we've talked about it a lot, but what exactly is it?
Cholesterol is a fat-like substance, a steroid, actually. And it's essential for a lot of things our body does.
But too much of it can be a problem.
Right, especially for our heart health. Now, remember those different types of lipoproteins?
Chylomicrons, VLDL, IDL, LDL, HDL, all those acronyms.
They all play a role in how cholesterol is transported and used in the body. And it's when those lipoproteins get out of balance that we start to see problems.
Like high LDL cholesterol.
To bad cholesterol.
And low HDL cholesterol.
The good cholesterol.
And that imbalance can lead to cardiovascular disease.
It can. LDL cholesterol, that's the one that tends to build up in the artery walls, leading to atherosclerosis.
And HDL cholesterol, that's one that helps clear out the excess cholesterol.
Exactly. Now, what about hypercholesterolemia?
Hypercholesterolemia. That sounds serious.
It's just the medical term for high cholesterol.
Oh, okay. So it's a fancy way of saying what we've been talking about this whole time.
Right. Now, foam cells, those are important to remember.
Foam cells, those are the macrophages that gobble up cholesterol, right?
Right. And they become engorged with it and contribute to the formation of those atherosclerotic plaques.
So they're kind of like the villains in this story.
In a way, yes.
Now, let's revisit HMG-CoA reductase inhibitors.
Our good old statins.
Right. What does HMG-CoA reductase even mean?
It's an enzyme, a very important one when it comes to cholesterol production. It's called hydroxymethylglutarol coenzyme A reductase, but we just call it HMG-CoA reductase for short.
I can see why. So statins block this enzyme.
They do, and that's how they reduce cholesterol production.
Okay, makes sense. Now let's talk about the nursing process. How does it apply to antilipemic therapy?
The nursing process, it's the framework that guides our care. It's how we make sure we're addressing all of our patients' needs.
And it's a systematic approach, right?
It is. There are 5 steps.
Assessment, diagnosis, planning, implementation, and evaluation.
You got it. We start with assessment, gathering all that information about the patient, their health history, their physical exam, their lab results.
We're painting a complete picture of their health status.
Right. And then we move on to diagnosis.
That's where we use our critical thinking skills to figure out what's going on and identify the specific nursing diagnoses that apply to this patient.
Exactly. And those diagnoses might include things like, well, ineffective health maintenance related to lack of knowledge about hyperlipidemia.
Or risk for ineffective therapeutic regimen management.
Right. Or maybe anxiety related to the diagnosis of hyperlipidemia.
So we're identifying the specific areas where we, as nurses, can intervene and make a difference.
Exactly. Once we have those diagnoses, we move on to planning.
Planning. So we set goals.
We do. We develop a plan of care that outlines the interventions we're going to use.
So we're creating a roadmap for our care. What kinds of goals might we set for a patient on antilipemic therapy?
Well, we might want to improve their understanding of hyperlipidemia,
Help them manage their medication regimen effectively.
reduce their anxiety.
And what about interventions? What are some examples of things we might do?
Well, we might provide patient education about hyperlipidemia, lifestyle changes, medication management.
We might teach them strategies to improve their adherence to their medication regimen
We might offer emotional support.
and coordinate care with other healthcare professionals.
Right. It's all about meeting the patient's needs.
And then we move on to implementation. That's where we put our plan into action.
Exactly. We deliver those interventions.
And finally, we have evaluation.
Evaluation is all about assessing how effective our interventions have been. Have we achieved our goals?
And if not, what do we need to change?
Right. We're constantly evaluating and adjusting our approach based on the patient's progress.
So it's a dynamic process, not just a one-time thing.
Exactly. Now, I think it's time to put our knowledge to the test. Let's do some review questions.
Review questions? I love a good challenge.
Okay, here's the first one. Which statement made by a patient prescribed atorvastatin indicates a need for further teaching?
Atorvastatin. That's a statin. So we're thinking about those potential side effects and drug interaction.
Right. So which statement would be a red flag? Option A. I'll continue my daily walks even though I'm taking this medication.
That sounds good. Exercise is important.
It is. Option B. I'll follow up with my provider to check my cholesterol levels regularly.
That's also important. Regular monitoring.
Uh-huh. Option C. If I have muscle pain, I should contact my provider.
Yes, absolutely. Muscle pain could be a sign of a serious side effect.
Okay. And option D. It's okay to drink grapefruit juice while taking this medication.
There it is. We know grapefruit juice can interact with statins.
That's right. So option D would definitely require further teaching.
Okay, good catch. What's the next question?
A patient who has been taking simvastatin for 6 months calls to report muscle pain and weakness. What is the priority nursing intervention?
Simvastatin, another statin. And muscle pain and weakness, that's concerning.
It is.
Yeah.
So what's our first priority?
Well, we want to make sure the patient is safe.
Safety first, always. Option A. Reassure the patient that muscle aches are a common side effect of simvastatin.
No, we can't just brush it off like that. Not with weakness, too.
Definitely not. Option B. Recommend that the patient stop taking the medication and notify the provider.
That sounds more like it. Better to be safe than sorry.
You're right. We need to stop the medication and figure out what's going on. Option C. Advise the patient to increase fluid intake and rest the affected muscles.
Well, rest and fluids are always good, but I don't think that's enough in this case.
It's not. Option D. Instruct the patient to take over-the-counter pain relievers.
No, that just masks the problem. We need to address the underlying issue.
Exactly. So the best course of action is option B. Stop the medication and notify the provider.
Okay, good. Next question.
The nurse is preparing to administer niacin to a patient. Which intervention is most appropriate to minimize the adverse effects of this medication?
Niacin. We're thinking about that flushing side effect.
Right, so how can we minimize that? Option A, administer the medication with a full glass of milk or a meal.
That might help with GI upset, but I don't think it would do much for flushing.
You're right. Option B, administer a small dose of aspirin 30 minutes before the niacin
And
dose.
that sounds familiar. I think I remember that aspirin can help with the flushing.
It can. It helps reduce the production of prostaglandins, which are involved in that flushing reaction. Option C, administer the medication intravenously instead of orally.
No way. That would bypass the first pass metabolism and could make the side effects worse.
You're right. And option D, instruct the patient to avoid hot showers or baths for 1 hour after taking the medication.
That might help a little, but I don't think it would prevent the flushing altogether.
It wouldn't. So the best option is B, give a little aspirin before the niacin.
Okay, makes sense. What else do we have?
Which statement by a patient taking cholestyramine indicates a need for further teaching?
Cholestyramine, a bile acid sequestrant. So we're thinking about those GI side effects like constipation and those potential drug interactions.
Exactly. Option A, I will take this medication 1 hour before or 4 to 6 hours after my other medications.
That's correct. We have to be careful about timing to avoid interactions.
Right. Option B, I will mix the powder with 4 to 6 ounces of juice or water and drink it immediately.
That's also correct. Cholestyramine comes in powder form.
Right. Option C, I will increase my fluid intake and fiber intake while taking this medication.
Yes, that's important to help with the constipation.
And option D, I can crush the tablets to make them easier to swallow.
Oh, no, that's wrong. We can't crush tablets that are meant to be taken whole.
Exactly. So option D would require further teaching.
Okay, got it. What's next?
A patient who has recently started taking gemfibrozil reports experiencing nausea and abdominal discomfort. Which intervention is most appropriate for the nurse to recommend?
Gemfibrozil. That's a fibrate, and it can cause GI upset.
It can. So what can we do to help this patient? Option A, take the medication with food or a glass of milk.
That seems like a good idea. Food often helps with GI upset.
It does. Option B, stop taking the medication and notify the provider immediately.
Well, we don't want to jump to that right away. Nausea and abdominal discomfort are pretty common with fibrates.
You're right. Option C, take an over-the-counter antacid before taking the medication.
An antacid might help temporarily, but it doesn't address the underlying issue.
True. And option D, increase fluid intake and eat a high-fiber diet.
That's good advice in general, but I don't think it would provide immediate relief for this patient.
Probably not. So the best option is A, take the medication with food.
Simple but effective. Okay, last one.
Last one. Which nursing diagnosis is most appropriate for a patient who is newly prescribed a statin medication and expresses anxiety about potential side effects?
So we're thinking about the emotional impact of this diagnosis and these medications.
Exactly. Option A, ineffective health maintenance related to lack of knowledge about hyperlipidemia.
No, that's not quite right. The focus here is on the patient's anxiety.
Okay. Option B, risk for injury related to potential adverse effects of the medication.
That's about the physical risk, not the emotional response.
Good point. Option C, anxiety related to perceived threat of side effects of medication.
That sounds like a much better fit. It addresses the patient's anxiety directly.
It does. And option D, deficient knowledge related to medication administration and potential side effects.
Again, that's about knowledge, not anxiety.
You're right. So the most appropriate nursing diagnosis is C, anxiety related to perceived threat of side effects of medication.
Excellent. Wow, we've really covered a lot of ground today, haven't we?
We have lipids, lipoproteins, all those different medications.
It's a lot to take in, but it's so important for nurses to have a solid understanding of this stuff.
Absolutely. We're the ones on the front lines helping our patients manage their cholesterol and reduce their risk of heart disease.
Exactly. Now, as we wrap up this deep dive, I want to leave our listeners with a final thought, a question to ponder.
A question that maybe sparks some further exploration of this topic.
Because as nurses, we're not just dealing with the science, are we? We're also dealing with people. Real people with their own unique needs and perspectives.
And sometimes those perspectives might not align with what we think is best for them, medically speaking.
Exactly. So how do we balance that? How do we advocate for our patients while also respecting their autonomy and preferences?
That's a tough one, especially when we're talking about medications that have both potential benefits and risks.
Right, like statins. Some patients are hesitant to take them because they're worried about side effects, even if their cholesterol is really high.
And some patients really struggle with those lifestyle changes. It's hard to break old habits.
It is. So how do we navigate those situations? How do we help our patients make the best choices for themselves?
Well, I think it starts with communication.
Open and honest communication.
We need to listen to our patients, understand their concerns.
And provide them with evidence-based information so they can make informed decisions.
Exactly. But at the end of the day, it's their choice.
We can't force them to take a medication or change their lifestyle.
No, we can't. But we can be there to support them no matter what they decide.
And we can help them weigh the risks and benefits.
Absolutely.
Well, I think that's a great place to end our discussion today.
I agree.
We've covered a lot, but I hope you've all found it helpful.
And maybe even a little bit inspiring.
Because managing lipid disorders is about so much more than just medications.
It's about taking a holistic approach to patient care.
It's about educating our patients
Empowering them.
and working together to achieve the best possible outcomes.
Couldn't have said it better myself.
Thanks for joining us on the Vital Signpost. Stay well, everyone.